again to this European Climate and Health Responders course. For those of you who have missed the first session, I'm Chiara Cadeddu. I'm the team chair of Planetary Health at the Erasmus School of Health Policy and Management in Rotterdam, the Netherlands, and I'm co-hosting the 7th session today with Doris Zialic, who is a medical resident in public health at Università Cattolica del Sacro Cuore in Rome, Italy. So today we are at the 7th session, and today's focus is sustainable healthcare. So this session will analyze the contribution of the healthcare sector to the climate crisis, its climate vulnerabilities, and the ways in which healthcare facilities can become more resilient in the face of increasingly frequent and severe weather events. It will discuss the terminology needed to understand different sources of greenhouse gases emissions, like scopes, and how to act to reduce them in the healthcare sector. We will also discuss existing reports and guidelines for the decarbonization of the healthcare sector that could be applied in the different settings. In particular, this session learning objectives are the following. You can see them in the slide. The first one is to define specific terminology used to describe different sources of GHG in relation to healthcare. Explain the contribution of the healthcare sector to the climate crisis, discuss pathways and guidelines to decarbonize healthcare and achieve net zero carbon, apply the principles of green healthcare management services and procurement, identify healthcare facilities, climate vulnerabilities, and evaluate their ability to respond to severe weather events and/or climate disasters, and finally, identify ways in which healthcare facilities can become more resilient of increasingly severe and/or frequent climate-related weather extreme events and help build the community climate resilience. Some logistics before we start. This is a 90-minute sessions like the previous ones. It will include expert lectures and 2 case study presentations. The session will finally culminate with question and answer section after each presentation. So please enter your questions for presenters in the Q&A that you find below. Sessions will be recorded and posted on the website within 24 hours, and reference materials and slide decks will also be included on the website. I would also like to remember you that you as participants have to attend at least 70% of the live sessions and pass the final exam with a score of at least 70% at the end of the course to be awarded with a certificate of participation. You should also join each class session using your personal unique Zoom link and complete the final exam using the email address used to initially register for the course. Your attendance is automatically recorded in the live Zoom session. The exam link will be sent on the final day of the class via email and will remain open for 48 hours, and certificates will be awarded on the 16th of April. So without further ado, I am showing you today's presenters. We will start with Dr. Erik van Raaij from the Erasmus School of Health Policy and Management here in Rotterdam, the Netherlands. Then we will have 2 case studies. The first one presented by Mrs. Mette Stokholm from the New North Zealand Hospital in Denmark. And the second one from Dr. Koonal Shah from the NICE, United Kingdom. So I give the floor to Doris to introduce our first lecturer, Dr. Erik van Raaij.
Good morning and welcome everyone. It is with great pleasure that I introduce today's lecturer, Professor Erik van Raaij. He is a professor of sustainable procurement in healthcare at Erasmus University in Rotterdam. His current research interests include planetary health, healthcare supply management, buyer-supplier relationships, healthcare contracting, and empirical research methods. He teaches in various courses on topics such as healthcare procurement and value chain management, healthcare supply chain management, and empirical research methods. And he's an engaged speaker on various topics such as circularity in healthcare and value-based healthcare. Erik, please, the floor is yours.
Thank you very much, Doris, and thank you very much for having me in this program. Before I start sharing my slides, I've actually brought something with me, and maybe some of you in the audience know what kind of device this is. You might think it's something to pick up paper around the roads, but of course that's not what I have in my hands here. This is a medical device which costs about 600 euros a piece, used by surgeons, and it's a so-called endo cutter. And this 600 euro device is a single-use disposable device, meaning that after being used for maybe a couple of minutes, it goes into the trash, and in the Netherlands, it will be incinerated. So the value of 600 euros goes, after single use, straight into the incineration, and the whole thing will be burned. This is one of the reasons why I'm so interested in the topic that I'm going to talk about today, which is sustainability in healthcare. And I'm going to cover a couple of different areas. I would like to discuss with you what the actual footprint of healthcare is. I would like to discuss with you how to analyze the impact of healthcare. But I think also very importantly, talk about how to take action to reduce the impact of healthcare on the environment. So starting with the footprint of healthcare, over the past years, quite some numbers have already been collected, and I'll be sharing also some experience straight from Rotterdam, from the Erasmus Medical Center, but of course also the international literature and numbers that we know from international studies. But this is a bed in the Erasmus Medical Center here in Rotterdam, and we took this picture to show all the waste that is generated in the intensive care. You see also the trash bags ready. Our analysis has shown that in the intensive care unit in Rotterdam, every single patient every day generates 7 bags of waste. And like I already said, that will be incinerated, meaning that not only in the production of these materials, there has been an impact on the environment, but also at the end of life, being incinerated, there's even more emissions. So there's been a recent study for the Netherlands that has shown that if you look at the total Dutch economy, and you would then identify the different sectors and what their CO2 equivalent footprint is within that economy, then healthcare in our country accounts for 7% of the total footprint of our economy. So that's in terms of emissions. Of course, there's also waste generation. About 4% of the total waste generated by our economy comes from the healthcare sector. We use a lot of water, a lot of raw materials, for instance, to manufacture the device that I've just shown you. 13% of raw materials used by our economy can be ascribed to the healthcare sector. And in order to, for instance, grow trees to make paper and other products, there also land is being used across the globe, and the healthcare sector accounts for 7% of land use. So what we're showing in the graph on the right-hand side is that while on the one hand, the healthcare sector is there, of course, to reduce the disease burden by executing all these activities. Greenhouse gases are emitted, fine particles are emitted, and via a process of climate change, global warming, we see that diseases are spreading. There is more heat stress. There's an increased risk of floods, especially in our country, and these are factors that in fact, increase the disease burden. So this is a vicious cycle that, of course, we need to see how we can cut it. Now, I have to tell you that this is an analysis including the so-called scopes 1, 2, and 3, and I will explain on the next slide. But this means, in short, that these percentages, they relate to the whole set of activities all across the world that are needed to produce the products and to prepare all the services, all the inputs that the Dutch healthcare sector needs. So it is the total footprint that we generate across the world to keep the Dutch healthcare sector running. So it's important to understand what scope 1, 2, and 3 mean. I'm sure that many of you have heard it before, but maybe not all. When we talk about scope 1, 2, 3, we talk about the different sources of emissions, and scope 1 relates to the activities of the company or the industry in question. So when we talk about scope 1, it means for the Dutch healthcare sector, what is being generated here directly by all the actors in the healthcare sector, or if you would calculate it for a single hospital, what are the emissions generated by that hospital? Scope 2 relates to the energy that is purchased by that company in the middle, the reporting company or the healthcare sector. They need energy, and it means that there are other companies producing energy generating emissions. That is scope 2. Scope 3 relates to all the upstream, the supply chain activities and the emissions generated there, plus the so-called downstream emissions, because you might be a company in the middle of a value chain, and there are also actors downstream in the value chain, and your products also are used there and they generate emissions. So that's also related indirectly to your activities. So scope 1, what you generate, scope 2, the energy that you consume and the generation of emissions related to that, scope 3, all the upstream and downstream supply chain activities. So also a very recent study here in the Netherlands of a large university hospital, but it has not been published yet. That's why you cannot read the numbers in the figure, but I took out a couple of key numbers there. This is the analysis for one hospital. And then you see that scope 1 is actually relatively small. So the emissions generated by the direct activities of the hospital are not so large related to the total. Scope 2, which relates to the energy consumption, is already sizable. 20% of the total footprint is scope 2. But scope 3 is by far the largest. In total, 75%, of which 15% is downstream, and 60% is the supply chain in which the products are produced that are in the end used by the hospital. And if you would then zoom in on that scope 3 upstream supply chain emissions, of this, pharmaceuticals account for 40%. So first of all, scope 3 is by far the largest, and then within scope 3, the production, the chain of pharmaceuticals is the largest. So this gives us already a bit of an impression of where to find the top impact categories when we think about the impact of healthcare on the environment. But there are more studies. There's, for instance, also a recent study of 33 acute care hospitals in Switzerland. And what you see here in the different bar charts is each bar chart relates to a certain type of impact. So global warming potential, the very first one, relates directly to the emissions we were talking about. But you see that they also look at the impact on ozone depletion, on acidification of the environment, toxic materials, again, land use, water use. So you see a whole host of possible impact categories that you can look at in order to understand what is the impact of healthcare activities on the environment. The different colors in the different bars indicate what type of activity in the healthcare sector are the reason for these impacts. And for instance, you see quite a bit of yellow, especially here, and yellow relates to the electricity generation for these 33 hospitals in Switzerland. But you also see this brownish color, and that actually relates to catering. So this is the food that is being prepared, consumed, but also in part thrown away for the use in these 33 hospitals. So we can see that food and beverages are also an important reason for behind the emissions and the environmental impact of a hospital. And here you see another brownish color, darker brown, relates to textiles, and it is about water use. This is for washing textiles. Reusables need to be washed. If they're single-use disposable, of course, you don't need to wash them. But if you switch to reusables, they need to be washed, and then you get an impact on water use. So this is a nice example of how you can analyze the different activities that are related to the healthcare sector, but also where their impacts are. Maybe just quickly one more. The gray area is construction and building infrastructure, which also has an important impact on the environment. So if you would look across different studies, this is my conclusion of what the top impact categories are of healthcare. So scope 3 is larger than scope 1 and 2 combined, which means that in order to do something about this, you need to collaborate with suppliers. So it's no coincidence that with my chair in sustainable procurement, I'm very much interested in how to work with suppliers and the supply chain to reduce the environmental impact of healthcare. Within scope 3, pharmaceuticals are very important. So you also need to think about how prescription behavior of healthcare professionals can have an impact on the environment. But because less prescription means less production needed, also means less waste. So it's also the behavior of healthcare professionals that can have an important impact. We've just seen that food and catering is also an important category. Energy consumption, which is basically scope 2, is an important one. And then we see from some analyses that mobility, so transportation of healthcare personnel, but also patients, family, and when we talk about the university hospital, students, is also an important category. And we have this category of construction, building, and infrastructure. So there's many more reasons why environment has such an impact on the healthcare than just the medical device I showed you at the start of today's lecture. So let's have a look at what type of analyses methods are out there to calculate the impact of healthcare on the environment. And these are analysis methods that we also use here when we do research on to what extent does the healthcare sector impact the environment, and different methods relate to different levels of analysis. Many of you will have heard of the so-called LCA, the life cycle assessment, or sometimes called life cycle impact assessment. And this is typically done at the product level. So again, thinking about the device that I showed at the beginning of today's lecture, you could have an LCA calculating what the impact is of all the activities that are needed to produce this medical device, but also to incinerate it at the end of life. So life cycle assessments, LCAs, very important to get a good understanding of the impact of healthcare on the environment. I'll show you an example of each of these. So I'll also show you an example of a so-called material flow analysis. And we've executed one for Erasmus Medical Center and a more specific one for the intensive care unit of the Erasmus Medical Center. I'll show you an example in a minute. What we also use is waste audits, meaning that we look at a department, but you could also look at a whole organization and analyze what kind of waste comes out of the department or the hospital as a whole, and categorize that waste in what kind of waste is this? Is it smart that it's being incinerated? Could it be recycled? What's the value of the different waste streams? So that's what we use waste audits for. There's also something called a care pathway analysis, which you use, the name suggests it already, at the level of care pathways. And a footprint analysis like the one I've shown you already 2 slides ago is also an analysis method that you can use. And I'll give you quick examples of each of these. So the LCAs are, I would say, the best known and maybe even the most frequently published type of analysis. And a very nice website to visit is www.healthcarelca.com. The mission of that website is to collect all published LCAs that are out there. So imagine you're interested to understand the impact of a certain product. The first thing you could do is have a look at that website, look in the database, and see what kind of LCAs might already be available for the product you're interested in. And very often these LCAs are about comparing two different types of product. It doesn't have to be that way. It can also be an LCA on a single product. But here, the example I'm showing you here is a publication where they compare the impact of a reusable duodenoscope, which is an endoscopy device. They compare that reusable version with a single-use version. And of course, the single-use version, the one at the bottom, has a linear path. It's produced, it's used, and it's disposed of, and it's incinerated, and the whole production chain and the incineration generates CO2 emissions. The reusable one will, of course, have a circular path where you need to produce less of them because you will be reusing them, which means that the production has less emissions, but also it's not incinerated after single use. It might be incinerated after being used 300 times. So also at the end of life, the CO2 emissions are lower. The only thing is that there might be an infection risk. And that's why you see at the top level that that might be a negative outcome. So this paper includes also infection risk in their analysis of whether or not a reusable duodenoscope would be a better choice as compared to a single use. Another example where you can see how disposables and reusables are being compared. Again, with a disposable device, a very clear linear path, single use, and then it will be disposed of. And the reusable, of course, has the steps where they are being cleaned and sterilized. But why I also included this one in the presentation is that, of course, sterilization as an activity also has a certain impact. And there's also materials, packaging. So there's also a supply chain of inputs for the sterilization process, and the process also needs electricity. So you need to take into account that the total system that you analyze also includes all the inputs needed for the cleaning or sterilization process. So that's how different so-called boundaries around the system. You need to make sure that you choose a good boundary around the system in order to make a fair comparison between disposables and reusables. And a third example is included because here you see that you can also think about hybrid solutions. To quickly explain what you see in this graph, the blue is a complete single-use set. These are sets to put a catheter into a vein at the patient. You can go for a completely single-use set, which is single-use textiles and single-use devices. You could go for completely reusable, which is at the top, the green one. But you could also think about a hybrid version where the textiles are single-use, but these devices are reusable. They can be cleaned and sterilized and used again. And in this particular LCA, they compare 3 different alternatives, which is also very interesting LCA to have a look at. And all of them are available at the website that I showed before. Moving on to another type of analysis, another method, material flow analysis. And what you do with this kind of analysis, you take a department or a complete hospital, and you're interested in what products are coming into that system that you have defined, but also interested in the actual materials where these products are made of. And of course, you will get a very detailed type of output. And you don't have to try to read the numbers and the words here. But what you see here is that we're looking at the intensive care unit of, in this case, Erasmus Medical Center. There are all kinds of products being used by that intensive care unit. And the products are made out of materials. And here we do an analysis where you can see what exact type of plastic is being used in which product that is ending up in the intensive care unit. What you also see at the output side is that there is a big stream of sewage, and there's also lots of water coming in, lots of fluids are being used. And all this red and orange streams is incineration, and this orange is high temperature incineration. And there's a tiny, you can't even see it, a tiny blue line with recycling of glass. That's the only product material that's being recycled in the intensive care unit currently. Simplified, it looks like this. It's the same analysis, but condensed to make it easier to see. So this kind of analysis gives you insight in not only in the products that are being used, but also the materials behind those products. And then you can start thinking about maybe recycling some of those materials, but also discussions about redesigning some of these products so that they don't use a mix of 3 different types of plastic, but maybe just one single type of plastic. That helps in making something recyclable. So here you also see at the product level, this is the same analysis, how many products of each type are being used per patient per day. 108 gloves per patient per day at the intensive care unit. 57 compressors, 24 syringes, 8 different bed liners. So this kind of analysis also opens your eyes to what are we doing and why are we doing this? That's of course then the next question. Why are we using so many? Is it avoidable? Can we maybe change something in our practices? Of course, I talked about waste audits. It's very closely linked, of course, to a material flow analysis, but in this case, it's simpler and quicker. You only look at the waste side, but it can also give you a lot of insight. It's really about making sure that the waste is collected and then, of course, in a safe way, analyzed and also sorted. And this can also give you a quick idea, and much quicker than the previous type of analysis of what is being used in a certain department and whether or not we can make changes to maybe product use. The care pathway analysis. This is a project run by another medical center, Radboud UMC, which is also a medical center, a university medical center in the Netherlands. And they have started a project to identify the impact of care pathways. And in this case, an example of cataract surgery. What are the different activities in the care pathway? What is the total impact? In this case, surgery of one eye, 72 kilograms of CO2 equivalent. But what is it made of? And then you quickly see the 2 blue boxes being very large, patient transportation and employee transportation. So the main driver of impact here is mobility. It's not the disposable and the reusable products, although disposables are also here, but they're not the main one. So you could think about, can we influence what type of transportation our patients take? But one conclusion also here was, if we give patients bilateral eye surgery, so 2 eyes at the same time and not having them come in 2 separate times, we're already making a big impact on patient transportation. So this kind of analysis makes you or helps you to rethink care pathways. They also have an example that you can find online on open heart surgery. So I already showed you this one, but this is an example of the footprint analysis. This was the 5th type of analysis method that I mentioned. And one more piece of information about this is, and this is important to know, behind those numbers are a lot of choices that researchers make about how to do the analysis and how to do the calculation. And these you could see as 2 extremes, where on the right-hand side, you see the LCA or LCIA based method. What this means is, if you want to make a footprint analysis, what you could do is, of course, collect LCA information about each and every product that's being used in a hospital as a whole or in a certain department. But then you need LCA information on each and every product. You need to know the physical quantities of each product, what materials, what types of plastic, what is the exact mass in grams or kilograms. What you get at the end is a very precise footprint, but it's extremely time consuming. Then on the other hand, on the left-hand side of this slide, you see a completely different type of method. It will be much quicker, but it's also much less precise. What you do on this side is you look at how much you spend on the purchasing of all the different products. So what products are being used by the hospital or by the department? How much do we spend on each of these different spend categories? And then we can use a database, for instance, the Axio-based database, and we can look up for €1 spent on this type of product, we should say, we should assume that there is this amount of CO2 equivalent emissions. So there's a lot of assumptions, and it's about the average emission related to a €1 spent on a certain type of product. So it's much less precise, but you can do this in a much quicker way. So in this case, the example that I showed you here was done mostly on the quick and less precise approach, here and there supported by LCAs where they were available, but for many products they were not available. And you can also mix the two. But it's important to know and understand if you are confronted with a certain number relating to a certain impact, what was the method behind it? So you should become a little bit skilled in how to read these kind of analyses. You already saw with the 33 Swiss hospitals that they had a whole list of different impact categories. And there are models out there that will help you decide, but also calculate what is the impact of a certain activity and a certain material and a certain product on these different types of impact categories. What you will see in quite many analyses, and this is the same example that I showed you earlier with the completely reusable set, the hybrid set, and a completely single-use set. Remember these kits to put catheters in the vein of a patient. And then the analysis shows the impact on resource use, including energy, the impact on climate change, mostly driven by emissions, CO2 emissions, the impact on ecosystem quality, which includes land use, water use, acidification, and the impact on human health, which is mostly related to things like fine particles, but also emissions, anything that can have a direct impact on our health as humans on the planet. So this is a nice example of how you can relate 3 different options, fully reusable, hybrid, or fully single use, and the different types of impacts. And with that material flow analysis that I showed before, also an analysis was done with what do the different products mean in terms of mass. So this is typically related to waste, but also the carbon footprint, the land occupation or the land use, and the water use. And the colors relate to different products. So you can follow this bluish color. If you go to the next one, it's not so large, it's down here. But in terms of carbon footprint, it's again quite sizable. In terms of mass, it's not so much. And if you would then follow this color, you will end up with gloves. So gloves, 108 per person per day, per patient per day, have an enormous water use in the supply chain. The production of nitrile gloves uses lots and lots of water. So what then is this one with the land use? The light green, almost no water use or not as much. Very small in terms of carbon footprint. Quite sizable here. It's the bed liners. So these are the bed liners in which in the middle there is the pulp made out of wood pulp, because it absorbs so nicely. But it means you need a lot of land to grow the trees to turn into pulp for the bed liners. So making distinction between different types of impacts also helps you to identify different products that have different kind of impacts on the environment. Now, and one model to sort of summarize all of this is this model where you see the same 4 endpoints that I showed before: human health, ecosystem quality, climate change, and resources. Here you see many of the different dimensions that also were shown in the 33 Swiss hospital example. And if you do LCAs or LCIAs, in this case called LCI, you can calculate the impact of a certain product or activity on these different midpoints and also on the endpoints. For me, a very important question that's left, of course, is can we do anything about this? And what can we do? And what kind of models could be used in order to think about what kind of action to take, but also where to take actions? Because I hope that by now I've convinced most of you in the audience that action needs to be taken and it's actually very urgent. A model that I find very inspirational is often called the 10R framework, but for the critical person in the audience, quickly counting the number of words starting with an R in this figure, you will see that there are actually 12 here. So that's why I put 10R between quotation marks. But these kind of models are often known as 10R frameworks, and they help you think about where to have relatively most impact with your actions. The higher R strategies are the one in green. The lower R strategies are the ones in white. And while maybe at the start of today's session, you thought recycling is a very good approach to reduce the impact of healthcare on the environment, recycling is actually a very low impact strategy. Recover means recovering a little bit of energy when you burn waste. And yeah, the 600 euro medical device that I showed you at the beginning, and then maybe recovering a couple of cents in terms of energy when you incinerate it, we shouldn't be talking about those kind of solutions. Well, only if nothing else works, we move to the lower impact R strategies. But rethinking healthcare, redesigning products, refusing to wear gloves when you don't need to, reducing the amount of bed liners that you use because maybe a piece of paper would be just as good, or maybe some other material, a washable material. So reduce, refuse, redesign, rethink, those are our strategies that can have a much higher impact because they're very often about not having to produce the product at all. So you're intervening much earlier in the supply chain. And while if you, in a linear economy, you would build up all the value with all these activities in manufacturing, assembly, retail, all the way up to the surgeon. And then he or she uses it and throws it in the trash. It means that it rolls down the other side of the hill and goes all the way down to all the value being lost. We want to keep materials and products high up on the hill, or rethink in such a way that it's a different product coming up the hill, or maybe we don't need that product at all. Now, if I show the 10R framework, I have to show this one as well because it's more complete. The 10R framework is about the right-hand side of this so-called butterfly model of the Ellen MacArthur Foundation. And what this model adds to our thinking is that while the 10R framework is about physical materials and finite materials that we try to keep in the loop for as long as possible, the left-hand side is about using more bio-based materials. And of course, that could also be a part of the answer to the question how to reduce the impact of healthcare on the environment. But there will still be many devices, many products in healthcare that we cannot make out of bio-based materials. So at the right-hand side is also still very important. Where could we intervene? Well, this is a list I created myself, so you will not be able to find it anywhere in a published source. And I'm thinking about how to make it even richer, but I started to see that a lot of places where you can intervene actually start with a P. And one of them, of course, is procurement and the products that we procure. And we can have a big impact by rethinking what we buy, how much we buy, from whom we buy. I already mentioned pharmaceuticals and prescription behavior. And that's also a category, pharmaceuticals, and especially the production chain for pharmaceuticals, where we can make a large impact. So prescribing less, prescribing maybe different pharmaceuticals, that's another way, another place to intervene. but also protocols and processes. So, for instance, Erasmus MC had a protocol that when a patient leaves the intensive care, everything in the room is thrown away, including everything in the drawers, which is not even, it's still in their packaging, but everything would be cleared out, goes into the trash, and is going to be incinerated. The new protocol says we will make a distinction between infectious patients and non-infectious patients. And based on what type of patient is leaving the ICU, there's different protocols on what to throw away and what can be kept in the room for the next patient. So rethinking protocols and processes can also have a big impact. And of course, the real medical procedures, the care pathways are also a place to intervene. I gave you already the example of cataract surgery, and that bilateral surgery will reduce patient transportation, which was the biggest source of impacts for that particular pathway. So we advocate in our so-called ASHER program, which stands for Evidence-Based Strategies for the Circular Hospital. It's a funded project that we are running. It started this year. And in the ASHER project, we believe in what we call a total value chain approach, meaning that there's many different places where you can intervene. Healthcare professional behavior, waste management, purchasing, influencing the supply chain in terms of product design, production processes, trying to avoid a lot of logistics flows, all transportation has an impact. And then making so-called multi-criteria decision-making about all these different decisions in the value chain. So in our ASHER project, we have all these different specialties involved. So healthcare professionals, but also product designers. We have purchasing involved. So we try to cover that whole value chain. And what do we mean with multi-criteria decision-making? That's the realization that improving in the area of sustainability often means also impacting other performance areas. There's always a question about safety. Does infection risk increase if we go for a reusable medical device? So you need to think about the safety of the patient, but also of the professional. Sometimes a sustainability initiative means additional work pressure. And in our country, we have a shortage of healthcare professionals, especially nurses. So sustainable alternatives should not increase work pressure a lot, and it would even be better if it would decrease work pressure. So we need to think about that as well. Some people will claim sustainable solutions are more expensive, and we need to talk about whether there is a positive or a negative impact on cost. And in the end, we practice healthcare because we are focused on good healthcare quality, good outcomes. And of course, we need to think about, does the sustainable alternative impact health outcomes in any way? A lot of you might think that there are trade-offs, that sustainable is more expensive, or sustainable is less safe, or sustainable means additional work. Now, it could, and then creating a matrix like this might help. This is a student project, a master thesis, where a student has analyzed 3 different types of video laryngoscopes. Those are small devices that you can use to look in someone's throat before you intubate the patient. And you can have them single use, hybrid, or completely reusable. And this student has looked at all the different dimensions, safety, workload, cost, in order to make a fair comparison between the different alternatives. And there are clearly trade-offs. But, and this gives a lot of hope, I think, there are also examples where there are no trade-offs at all. So this is about replacing infusion and pump lines in the intensive care unit. And the common practice was 96 hours of use, and then you need to take them out and replace them with fresh tubes. But there was not a clear reason why it should be 96 hours. So the question was raised, could we also leave them for 144 hours? Different studies were done. Infection prevention said it's completely safe. There are 3 international studies showing it. The hospital did its own tests. flows remained constant. Nothing happened to the lines. They stayed completely intact. So this means you have to procure 40% less, which is a cost improvement. You throw away 40% less, so you have less waste. You have to replace less often, so it's less work for healthcare staff. And most interestingly, infection risk actually seems to also go down. And there could be a mechanism explaining this because there is less often people interfering with this system in the intensive care. So this looks like an example where there's actually green lights on all the different elements of the multi-criteria framework. So finally, how to take action. And this model is also newly developed to think about the stakeholders that might be involved if you want to take action, and the distance between you and the stakeholders, also giving an impression of how much effort it would take to involve a certain stakeholder, or maybe even change that stakeholder because you might be dependent on them. So what we see is that in the hospital, there's a lot of green teams consisting of healthcare professionals with department managers very close to where the action is, and they can also take very quick action. And there's a lot of good examples of green teams making sometimes small, sometimes slightly larger sustainable changes in the hospital. But very often they need the involvement of other people in the hospital. So we're still within the hospital boundaries, but what helps a lot at Erasmus Medical Center is that one member of the board of directors has sustainability in her portfolio and is very supportive of anything going on in the hospital related to sustainability. Infection prevention is on board. There's good relationships with purchasing. If you get into reusables and you need all these loops, you need material logistics to be involved. And of course, the central sterilization department is very important. So you need to build good relationships with different entities within your hospital. But then there is a next layer of suppliers that you need if you want to change something beyond the borders of the hospital. And there it helps if purchasing is well connected, because they are the bridge between the hospital and these outside parties. So make sure that you have them also in your set of stakeholders that you manage. And sometimes you have to go also beyond that set to, for instance, regulators at the European Union level, at the country level. You might have to involve insurers. They might even be willing to invest. Imagine that a sustainability initiative needs a one-time investment that will pay off over the next 15 years. You might be able to get an insurer involved. And there are, of course, other outside parties that have opinions or that might be important groups that have power in whether or not your initiative will or will not take place. So my field is procurement, and I'm thinking in my research, what kind of business models for suppliers help to create sustainability? How can we change tendering processes that we use to purchase products that if we change it in a certain way, we might be incentivizing more sustainable solutions? What are the purchasing criteria that we should use in order to evaluate what the different suppliers are offering to us? And maybe there are new contract types that we can use in order to incentivize suppliers to come up with more sustainable solutions. So to conclude, what I think are the take-home messages: healthcare has a considerable footprint, so it's important to work on this. Data is key. As soon as you have data, pictures, numbers, it's much easier to convince others to work with you. The insight that 108 gloves per patient per day were used was already a number that started to buzz around the department, and everyone started to think about, is it really necessary that we use that many gloves in our department? So data, facts is very important. But your local situation is also important. For instance, if you are in Australia, your energy mix is very different from Europe. You will use much more brown coal instead of renewables. So the LCA outcomes will be different if you calculate it for a situation in Australia versus the Netherlands. So you need to be aware that there are assumptions in models that you need to check. There's many starting points to intervene. There's many different things you can do. Involve staff, go through these lists and see where you can take action. And sustainability can actually be cheaper. It can be safe, it can be less work, but there might also be situations where trade-offs are necessary. My advice would be to take that total value chain approach that I've shown in one of the figures. And of course, but that's why I'm a professor of procurement, I would say that purchasing is a very important change lever, a very important stakeholder to involve if you want to think about sustainability. So thank you very much. That was what I wanted to share with you, and I'm happy to take questions.
Thank you very much, Erik, for this insightful presentation. And yes, definitely there is an urgency to act, also because we know that the healthcare is in this paradoxical situation of healing diseases and new diseases linked to climate change, but also at the same time decrease its own impact on climate and environment. So there are a lot of questions I see, and that's a very good thing, but let's start from the first one that I see in the list, that is about the possibility that disinfection sterilization process of reusable devices could generate more emissions than using multiple disposal devices. What's your opinion on it?
Yeah, that's a very good remark, because imagine that this device, we would redesign it in such a way that it could be cleaned. Currently, it cannot be cleaned at all because there's too much going on here at the top of the device. So it has to be redesigned before it could become a reusable variant of this device. And yes, the person who asked the question is completely right. The cleaning process also generates emissions, and there could actually also be toxic materials being used in cleaning, depends on the type of cleaning that is needed. So there was, and that's a nice example, there was a study about a certain kit, the kits that I also showed the example, the kits to put intravenous catheters in patients. There was first a publication that said single use has less emissions because the reusables consume so much energy that the emissions are higher. But this was in Australia. The first study was in Australia, where they use brown coal for energy. So the emission related to the energy needed for cleaning is different from a situation where the energy mix has a lot of renewables. I can imagine if you do this in Norway or in many other European countries, your LCA would give you another type of output. So it's very important, related to the energy and material usage of a cleaning process, to also understand where you are doing this and what type of cleaning process would have to be used.
Thank you. A second one is, can waste auditing include waste sampling to determine the segregation practices of waste generators?
Mm-hmm. Yeah, interesting. Now, yeah, as you've seen in the intensive care, hardly anything is recycled. So there, the waste stream is all going to the incinerator, but in other departments, there is also recycling going on. So there is waste separation, and you could indeed also use a waste audit to understand, are we already separating waste in the best possible way, or is maybe a lot of recyclable waste still ending up in the bin that goes to the incinerator? So that could indeed also be a reason to start a waste audit. Yeah.
Okay, third one is actually not about supply chain and purchasing, but it's about education of health workers, and it asks if there are studies aiming at finding if education of health workers is required, what are the current policies and practices, which is the situation for some pharmaceutical medical device companies and their approach to sustainability.
Yeah, so I hear at least two questions here. One about education, and the other one about the suppliers and specifically the pharmaceutical suppliers. Now, personally, I'm not yet looking at the pharmaceutical supply chain. It's very different from the supply chains of medical devices. I do want to look at it in the future, but at this moment, I cannot speak from my own experience there. So I'm sorry, I have to park that question for maybe a couple of years in the future. The one about education. It's an explicit part of our Azure project. So one of our main ways to disseminate what we find is to bring it into the curricula of, for instance, a nursing curriculum. It's one of our partners in the consortium. So that's a very explicit way of disseminating the knowledge that we will generate. And we also see that curricula of medicine here in the Netherlands are changing. So there are currently discussions going on how to make sustainability, ecological sustainability, a core element of the curriculum at university hospitals. I don't know about a study looking into this, so maybe there's still room for a study looking at to what extent it already exists across different curricula, across different countries. But I would have to look into it in order to know and to give an answer whether it exists, yes or no.
Yeah, if I may, I can add on this because we are working with USFER to integrate in the curriculum of public health professionals the need for sustainability topics and need for sustainable healthcare program, a sustainable healthcare program, especially for public health professionals, but I think it's something that relates to any kind of health professional. Another question, maybe the final one, is there a growing desire for compostable medical products?
Interesting question. I can keep it short because I don't really know. It does pop up in the discussions now and then, but not very often. What you do see is the question, plastic waste, can we use pyrolysis to create fuel, basically, out of plastic waste? So that's not the same thing as compostable. So there are, there are some initiatives, but I don't think it's mainstream yet.
Okay, so I think we can move on with the case studies. Thank you again to Erik for this presentation. And Doris, the floor is yours.
Thank you, Erik, for this interesting lecture. It is now time to move on the case studies, and it is with great pleasure that I introduce Miss Mette Stokholm. She holds a master's degree in architecture from Royal Danish Academy, and as project manager, she has been working with complex and ambitious architectural projects for 2 decades and has been responsible for the development of the design program for the mega project New North Zealand Hospital, along with the involvement of clinical users. Mette presently serves as design director in the executive management team, which is heading the construction of the hospital. Mette, please, the floor is yours.
Thank you so much. I will just start with sharing my screen. Just a second. There you go. Thank you for inviting me. You know, we love talking about our fantastic new project here up in north of Copenhagen. I will give you a very short introduction to the project, and I will also try to explain a little bit about how we have tried to incorporate sustainable elements in this quite big mega project, and also how we have tried to deal with potential impacts of negative climate changes. Yes. The reason why we are constructing this new hospital is because there was a decision of a huge investment in Danish healthcare from the government around 15 years ago, and it resulted in 16 projects, big very big projects, but only 5 of them were actually greenfield projects. And New North Zealand Hospital is one of these 5 greenfield projects. This, of course, makes you quite humble and also, feel that this is the golden opportunity to really rethink how you could provide healthcare in the future. There were certain demands, of course, why the Danish government wanted to make this investment. They wanted to modernize the whole hospital structure. There was also a focus on patient-centered care, which basically meant that only single rooms were to be built in the future. But there was also a demand of having an efficient operational structure. So there is a demand on providing an increase in efficiency on 8%, which is quite a lot, and basically means that this is something that's staff related. Such a project, as I said, is about transformation, of course. It also shows this time like that. It takes a really long time to plan a hospital. That's a fact. And from where we started thinking about this and planning this hospital, hospitals were also pronounced in Danish. It's like house of the sick, basically the same in Dutch as and in German. Patients, they were just lying in the bed obedient, and the maximum of technology in hospitals at that time were telefaxes. Things moved on while we were planning. One thing was that we wanted to centralize all the care in order to provide the best care. There was a digital transformation as well. iPhones were invented during this period, and patients learned to Google, so they were not just that obedient anymore. They were actually asking questions. But during our planning process, also times changed actually much faster than we had anticipated. So, and the COVID played also a factor here. Technology has really moved into the hospital sector, I must say. Patients are demanding services now, and we are considering looking at our hospital facilities more as a health hub than a centralized facility. Patients are inpatients at home. We have moved around a third of our outpatient consultations out into the virtual space, and they're not coming back. We also started our project looking at what was already there, the new projects already in process, and we looked at them and thought we might be able to do something a little bit different. And you can guess which one of the projects are ours. We ended up with a brief that said cool facts that we were about to build 125,000 square meters with 570 patient rooms, single rooms only. This is an acute hospital, which means there are certain medical specialties needed there. It can change a little bit, and it has already during our planning period. So we are, already taking our flexibility principles into use. This will be the only hospital left in this area, which means that we are actually merging 5 existing hospitals, and we have already closed 3 of them. It's a big workspace, so we have 4,000 employees, and we have a generous budget of 1 billion euros. But of that, we need to use 20% on the medical equipment and technology. We have a really good design team. We have ended up with, after a project competition, the Swiss company called Herzog de Meuron, which is known for a lot of big, huge, complex projects around the world, but not so many hospitals at all. And that was quite deliberate from our side because we wanted a more curious approach to how to create healthcare facilities, and we wanted a closer dialogue with the design team instead of having hospital planners and hospital design architects that have already decided what concepts to be used. This was the site that we were given. It's a rural countryside outside a town north of Copenhagen. It's coming with a lot of beautiful nature, but it's also coming with a lot of wetlands and a very high groundwater level. And that made us use some methods of mitigating this problem. But most of all, we decided together with our design team that we wanted to create a hospital that didn't feel like a hospital. This should be part of a new community that was about to be developed around the hospital where that was supposed to be constructed. And we didn't want it to be somewhere where you were stigmatized. We asked, why does a hospital need to look so much, so institutional, so clinical? Could it be done in another way? Our architects showed what they have already done, some small rehab centers with healing settings, and they were designed for people, both for the people working there, but also for the people staying there as patients. And that was, that appealed very much to us. So we wanted to have this human perspective on how to create such a big structure. And we wanted it to be not just one single institution, but somewhere where you could make an asset to the community around it. So focus was, of course, on embracing nature, both outside and inside. We wanted a low-scale building, human scale. We didn't want to compromise it. Of course, we couldn't compromise on clinical and hygienic efficiency. This, of course, needs to be present. But we wanted to provide environment that appealed to both the staff and the patients. So whether you were in a surgical unit or you were in the lobby, you should be embraced by views to the nature. You should be embraced by natural materials and daylight all over where people are meant to spend time. The nickname came quite quickly. It was called the Pavilion in the Wood. It's a fairly big pavilion, but the scale is there, so it sort of makes sense. And we have promised to create the landscape back to the natural case that it was before. Right now, it's not like that, but it will eventually, because this was pictures taken before we made it into a construction site, and we have a concept of creating or getting the nature back all around the hospital, but also in a miniature scale in the interior roof garden. There's a roof garden that's on the second floor where all the patient rooms in the perimeter have a view towards, if they don't have the view to the exterior landscape. Connecting to the community also means a lot of connections. There is, of course, need to have a car circulation, but we have placed it quite deliberately in the outer perimeter of our building site. We have access with the bikes and pedestrian streets connecting it to all four corners. We have also very, very deliberately made a very short and access road for all the heavy transports to the hospital. All the supplies that Erik just explained about will only be entered to the one surface village that is detached from the main building and only connected with a tunnel underneath. Such a big structure is part actually of our regional plan, and it came together. The location was chosen where there also was a possibility to create a new train station. And that's the little map in the corner showing where the train station has been constructed, and it is already in use, and it makes a close connection with public transportation for the hospital. I started with saying that I would also explain a little bit about the site circumstances that we were giving. Because of this demand of combining the train station with the hospital, with the new hospital, we didn't have any choice on where to build. So we were giving a site where there was already quite high groundwater levels that we needed to control. And we could also, of course, we needed to face extreme weather situation, being a low-scale building with inner courtyards and all the vital functions of the hospital being to lower levels of the building. We also needed to mitigate that. So what we've been doing is that we have created rainwater detaining reservoirs around the hospital, being part of the natural landscape actually, but being able also to control the rainwater in situation, for instance, with the 100 years events. We also have a connected system of trenches around all our parking spaces that allows us to also detain the water, the rainwater, before it's being released to the local streams and eventually the sea actually. We are so lucky that we got a lot of protected nature so that we don't have to build parking spaces in there. That's sort of like an asset. And a lot of vegetated areas as well, also to contain some of the water. And the inner, as I told you, the roof garden, it's 15,000 square meters inside the building, and we have also created that as green roofs. One thing is that we were not allowed to make permeable surfaces in our car parking spaces. For instance, we were planning actually originally with gravel, but we couldn't do that because we needed to comply with the winter maintenance policy, salting, which has also been an issue in our trench system. Also, how to deal with salt there. We are in Denmark, is a Nordic country, and we do have frost and snow during winter. So here, the operation, the wins above sustainability, I must say. 100 years event scenarios, we are also planning with different climate models. I must say that right now we are experienced that the 100-year events are not coming with they're coming much more regularly than 100-year. We already experienced it during the construction. But our engineers, they have been doing different time scale modules, and they're mapping. This blue spot mapping is showing in case of flooding where we can control the water. If we cannot contain it in what the map shows, the car parking will be flooded as well if it's like a very, very serious event. But we are, we have prevented that vital functions inside the hospital will be flooded. We have a very heavy pump system inside the inner courtyards. The inner courtyards that provide all our clinical functions with daylight, so they're much needed. But they have a drainage and a pump system that are dimensioned according to these serious events. One of my last pictures here is one of our retaining reservoirs, which will be created or reshaped back to a natural landscape, and they are actually already here, and the swans, they're already here as well. Of course, this was about the climate change challenges. We also have incorporated sustainable elements in this. We plan with district heating and cooling. We have a lot of solar panels on the roof, and we have decided that the present energy objectives, they are not enough. We are actually meeting future codes. So we're also planning that this hospital should at least have a lifespan of 100 years. So we don't need to do what we are doing now, closing 5 hospitals. And that means we also have a strategy of how to expand the hospital with up to 50% without messing up the infrastructure and the logistic flows. And we are also taking a lot of emphasis on this is a universal design, which means that the hospital is accessible for all without any special precautions. So we have all our fixed furniture and counters designed for everybody, and we have step-free accesses also everywhere, both inside and out. And this is my last image. This is from February, and I think that it's safe to say that this winter has been really wet. I think this picture shows it. You could see it on our site, but you could also see it in the surrounding fields and nature. That yes, winter is wet in Denmark. Thank you.
Thank you for this insight in your ambitious project. We leave the questions for the end and move to our last but not least presenter. We have the pleasure to host Dr. Koonal Shah. He's an associate director in the Science Policy and Research team at the National Institute for Health and Care Excellence. His project portfolio includes overseeing the NIC's Listens Deliberative Public Engagement Program, helping to establish a new process for making modular updates to NIC's manuals, and contributing to efforts to reduce the environmental impact of the health and care system. Koonal has a PhD in health economics and decision science from the University of Sheffield. He's a honorary senior research fellow at the Sheffield Centre for Health and Related Research, University of Sheffield. And please, Koonal, take the floor.
Thank you very much. So I'm based in the Science Policy and Research team at the National Institute for Health and Care Excellence, or NICE. At NICE, we produce evidence-based guidance and recommendations for practitioners and commissioners that guide the use of health and care resources by the National Health Service in England. So some of our well-known products are the evaluations of specific health technologies or health technology assessments, and also clinical guidelines covering entire areas of care. And was invited to present a case study of how NICE has approached the challenge of helping to make healthcare more environmentally sustainable. There was a recent Act of Parliament in England, the Health and Care Act, that places a duty on NHS England and NHS providers to adhere to 2 other acts, the Climate Change Act and the Environmental Act, and requires them to consider how they can support the UK in reaching net zero and other environmental targets. And what this legislation means is that the NHS's remit has expanded. It used to be just about supporting healthy people, and now it's about supporting both healthy people and a healthy planet. So the specific targets that the NHS has in relation to carbon emissions is to reach net zero by 2040 for emissions that it controls directly, and by 2045 for emissions that it influences. NICE is an arm's length body. It's not part of the NHS, and there aren't any specific implications of the legislation for NICE, but they provide additional rationale for any of our own efforts to support the NHS to reduce its environmental impact through our guidance and other activities. We've been taking small steps towards being able to measure and assess the environmental impacts of healthcare interventions. We're still at the very early stages of that journey, and we're certainly not ready to start incorporating environmental impacts into our assessments routinely. But in the absence of being able to do that, we believe that one of the best things that we can do for the environment is to help ensure that any care delivered in the NHS is necessary and of high quality, and we minimize the production and consumption of care that is low quality, on the basis that all healthcare produced and consumed has environmental costs. At NICE, we have a program of deliberative public engagement known as NICE Listens. Its purpose is to give us a public perspective on challenging ethical or social value issues that we and our committees need to consider when developing guidance. And in 2022, we were able to do a deliberative public dialogue on environmental sustainability and how the public would like NICE to take responsibility for making healthcare more environmentally sustainable. So we had a sample of 23 members of the public. They participated in 3 online workshops. I think there were about 10 hours of contact time in total, with pre and post workshop tasks. And they heard from a number of experts, did a load of work through case studies and various exercises to help them understand the topic and also understand NICE's role, and then make informed judgments about what NICE should be doing. Our main finding was that participants supported NICE taking responsibility to make healthcare more environmentally sustainable. Many of them entered the dialogue a bit skeptical about why this was NICE's business, and indeed why it was the NHS's business. The NHS, in their views, was about looking after people, not about looking after the environment. But what we observed was that support for environmentally sustainable healthcare grew as the participants learned how sustainability can support the outcomes that they were really interested in. So they were much more interested in things like improved population health, reduced burdens on the NHS, greater efficiency, convenience for patients. But they learned that sustainable healthcare often comes with those as co-benefits. So loads of the focus in this area of work is on trade-offs, difficult trade-offs between patient health outcomes and environmental outcomes. But based on this dialogue, we don't think this is where the public wants us to focus our efforts. We think they want us to focus on areas where there are co-benefits. So other findings, we found that the public wants us to take action to help lower the demand for healthcare, like guidance on prevention, to reduce the supply of care that provides no benefits. They supported us providing information of the environmental impacts of care where that's possible, to support and facilitate shared decision making. They want us to influence the supply chain to be more green. And they also were open to the idea of us making green treatment options the default where appropriate for newly diagnosed patients. And under certain circumstances, they supported us moving towards considering the environmental impacts of interventions in our evaluations. Assessing environmental data and incorporating it into our health technology assessments is the area where there is loads of interest, and that was something that we investigated in a recently published journal article where we focus on that part of NICE's role as a health technology assessment body, and we identified 4 approaches that an HTA agency like NICE can take to consider environmental impact in our decision making. The information conduit role is distinct from the other roles. in here, the environmental considerations would not affect our own value judgments, whereas with the other three approaches, they are all potential approaches for combining environmental impact data with other types of impact data in decisions that we make about value, whereas the information conduit role involves us using our publishing power and republishing or repackaging environmental data that's already in the public domain or that's been submitted to us. And as we'll see in the rest of my presentation, NICE is already doing this in a limited capacity. Because of lack of time, I'm not going to go through the other ones, but you're welcome to take a look at this article, which is published in the International Journal of Technology Assessment in Healthcare, if you're interested. So this is an example of NICE taking an information conduit approach. So as well as our guidance products, which involve our independent committees making value judgments and making recommendations, we also have advice and information products. And one of these is an asthma inhaler's decision aid. You may be aware that some types of inhalers have a bigger carbon footprint than others, specifically pressured metered dose inhalers, because of the compressed propellant used to deliver the medicine, have a much higher global warming potential than dry powder inhalers. This is one area where environmental impacts are well established and there are high quality comparative studies published. We recently updated our decision aid to provide information on the environmental impacts of different inhaler options, and that's to facilitate conversations between patients and healthcare professionals and to allow them to make more environmentally friendly choices. We've been really careful not to frame anything in the aid as coercive or something that patients should feel guilty about. We make it clear that patients should speak to their healthcare professional about their decision and before making any changes, weighing up the various advantages and disadvantages that matter to them personally. So as you can see from this slide, we provide in the aid simple, easy to understand information on the carbon impact of different inhaler types. We briefly explain why that matters, and we show how the doses of these inhalers compare to other activities with well-estimated environmental impacts, specifically here, petrol car journeys. And as well as inhalers, there's another well-known environmental hotspot, and that is anesthetic gases. There are four main inhaled gases used in anesthesia, and there is significant variation in the environmental impacts of these different gases. Desflurane is known to be a problem gas. Its global warming potential has been estimated to be around 40 times that of an alternative such as sevoflurane. The NHS in England announced the decommissioning of desflurane by early 2024 on the grounds of its global warming impact. But they identified that there may need to be exceptions for circumstances when it is necessary and acceptable to use it. Before the announcement of the decommissioning, there had been progress made in reducing the use of desflurane without NICE's input, but there was still national variation that existed. Because some anaesthetic practitioners were used to using desflurane or believed that it was still useful to use it. So NHS England felt that NICE had something valuable to offer in terms of our evidence review capabilities and our objective approach. So NICE has been working on an evidence summary, reviewing the clinical outcomes and the resource impact outcomes of desflurane versus other anaesthetic agents. And the purpose of the evidence summary is to understand whether there's any evidence that points towards the need to use desflurane in certain exceptional circumstances. So importantly here, we're not reviewing the evidence on environmental outcomes. We don't have the skills or expertise to do that. What we do have is expertise in reviewing evidence on clinical and resource impact outcomes. And unlike our health technology assessments or our guidelines, we're not making value judgments or any recommendations in this work. This is an informational product, and we're doing this to inform policy making and judgments by our system partners in NHS England. So linking back to the previous slides, what this helps to do is to ensure that patient outcomes and safety are not compromised by efforts to improve environmental sustainability. So that's in keeping with our remit, and it's in line with what participants in the NICE Listens deliberative dialogue told us. The timing of this session is a little bit unfortunate because actually the NICE evidence summary and the linked NHS guidance on desbrain are nearly ready, but not quite published. They're both due to be published by the end of this month. So I can't share the findings in this session, but if you're interested, please look out for updates on the NICE website where the evidence summary will be published in the coming days, and also the social media accounts of NICE, that's at NICE Comms, and the Greener NHS programme at Greener NHS, where announcements will be made. Thank you very much. That concludes my case study.
Thank you, Koonal. Hopefully we are out of time, so I will share my last slide just to remember. Yeah, please remember to fill in the post-session survey. You can see the QR code. So scan it with your phone camera or follow the link in the chat. Thank you very much to all the presenters today and to all the attendees, and see you next week, always on Tuesday, always at the same time for the next session of this course. Thank you very much to everyone.